coming. Welcome to the Falls Lecture Series. I'm Sue Kitchen. I'm not Sue Kitchen. I'm doing her job for a few weeks, so just facilitating this session. So just to welcome those that are here on VC as well. And the aim of these lectures is to increase and broaden our knowledge of current evidence, events and processes relating to falls and any practice changes that may need to occur. These sessions are aimed at all the multidisciplinary team. There's 10 copies, so help yourselves, and please, if you would sign in and provide evaluation at the end, that would be really good. And our guest speaker for today is Professor Keith Hill from Curtin University. I'd like to give him a big welcome. His topic today is a medley of falls evidence. Professor Hill is a top international researcher who's secured over $9 million in grant funding for research projects. He's had about 115 articles in journals, and his research areas of interest include falls prevention, gait and balance, assessment and interventions, healthy aging, stroke and hip fracture, rehabilitation, residential care. And thank you very much, Professor Hill.
Thanks, Anne. So I've talked to this group twice in about the last 18 months, and in both of those talks I focused specifically on what has been shown in the research evidence to work in hospitals in reducing falls in older people. There hasn't been a lot of new developments in that space since I was here last time, so in talking to Sue about what I would present this time, I'm focusing more on some community-based research work and work around transitions to home from hospital that I think will have some relevance to you, whether you work in the hospital setting or the community setting. So in particular, there's 3 bits of work that I'll be talking about, and these relate to a high-risk population, being stroke patients, and a new intervention that's been shown to work in reducing risk of falls in that group. Issues around adherence of recommendations to minimise risk of falls by older people, and the issues around why that's not terribly good at the moment and what we might be able to do in terms of doing that better. And thirdly, look at the impact of falls on carers, who are an important group, often older people caring for a frail, high-risk older person at home, and what the impact of a fall on that caring relationship is. So in the community setting, we do have a lot of very good research evidence around things that can work to reduce risk of falls. These are all randomised controlled trials. In the most recent Cochrane review, 159 studies with 79,000 participants. So this is a very well-researched area. The top part of that slide shows you a number of single interventions that can reduce risk of falls, including exercise, cataract extraction, medication reviews, home modifications, improved post-discharge follow-up, strategies to improve adherence in recommendations, vitamin D, calcium supplementation. For a small subgroup who have syncope, cardiac pacemakers have been shown to reduce risk of falls, and also a recent study looking at foot exercise, footwear and orthoses. So there's a lot of different single interventions. Those can be combined into multifactorial interventions using 2 or more of those approaches. And again, we've got good evidence in a large number of studies that we can reduce risk even in high-risk populations, such as people presenting to emergency departments, with that type of approach, often based on a risk assessment. But one of the big problems we've got is that despite that growth of research evidence in the last 15 years, if we look at one of the key indicators of falls in Australia, and that is hospitalisations due to falls, we haven't really made any inroads. So what this slide shows you is 3 age groups, 65 to 74, 75 to 84 and 85 plus, and these are rates of falls resulting in hospitalisation. And you can see that over this period of time, when we've had all of this good research happening, falls rates haven't really changed for the 65 to 74, 75 to 84, and in fact in the fastest growing part of our ageing population, which is those that are 85 plus, the rates are increasing. And that's important to realise what the impact of that is, because if rates stay the same, it means that case numbers, because of the ageing population, and every year there's more people in the over 65 age group, that case numbers presenting to hospitals are going to be going up considerably. So we can't afford to just see rates staying the same. We've got to see hospitalisation rates dropping markedly. so that the whole health system is going to be able to manage with this potential problem. So what we've seen is this massive growth in good research, but not really having any traction on the ground. We're not seeing reduction in hospitalisation due to falls. Now there's a lot of potential reasons why that might be, and in what I'm going to, the few snapshots I'm going to talk to you today about, I'm going to touch on a few of these, and there's a few that I'm not going to touch on. The first one I'll mention is inadequate funding for falls prevention, and that's not really one that anyone in this room can do anything about, but I just want to highlight it. Back in 1998 to 2008, there was a dedicated part of the Commonwealth that was responsible for falls prevention. There was some dedicated funding for falls prevention initiatives, and that stopped. State government funding, I'm not as familiar with the specifics over here, but certainly in Victoria, there's been no growth in falls prevention funding over a 10 or 15 year period. And if we think about the other area of injury that causes a major demand on health services, and that is motor vehicle accidents, there's 2.5 times as many hospitalisations due to falls as there are for motor vehicle accidents now. Motor vehicle accidents is an example where a large amount of resourcing and policy and planning and funding has gone in over 30 years or more, and we've seen massive reductions in injury-related hospitalisations and deaths. So injury prevention is possible with good resourcing, but what we're seeing in the biggest area of injury prevention now for in Australia in terms of hospitalisations, that we're not getting the funding that we require. Other factors are around limited targeting of falls prevention to key high-risk populations. The majority of the work looks at older people generally, and in my mind there are some subpopulations that have very high risk, and probably a need for some things to be done a little bit differently to what we would do for an average older person population. And so a few of these populations are people with stroke, Parkinson's disease, dementia and arthritis. And those high-risk populations, the risk is often double in those populations as it is in older people generally. We've got very little research evidence that things can work on reducing falls. So I'll touch on that to a degree. Limited engagement of older people in falls prevention. We know what looks promising from a falls prevention point of view with respect to the research. How do we get older people engaged in those interventions? There's limited early identification and prevention approach. Often from the health system perspective, we don't engage with an older person until they have a moderately severe fall. And I think we've got to get in far before that first serious fall occurs. There's limited partnerships between a lot of key stakeholders who could all have good, important roles in this area. There's barriers between settings, so community to hospital to residential care, and in fact the transitions between these settings are extremely important and periods of high risk. So the transition from hospital to home is a period of high risk for falls. There's also problems with the research side of things, and the emphasis in research is to have a very tightly controlled methodology that means that we can get some very good results, but often by doing that we actually take the research away from the way that things really would work effectively in a community setting. And so some of it's around sampling. Often we don't include people from non-English speaking backgrounds. We don't include people with cognitive impairment, and these populations are making up more and more of the older population out there. So our studies have got to be more representative of older people generally, and also the type of interventions we do. Often we've got very rigid structure around the interventions that are not realistic in a real life setting. And so again, we've got to be better at putting in place interventions in our research that is true life or real life settings. So I think there's a lot of reasons why we're not seeing impact even though we've got that good research. And these are areas which from a practice and a research point of view need fairly strong focus. So the first one that I'll touch on is around high-risk populations, and I'm just going to give you stroke patients as a bit of an example here. People who have stroke and are in hospital, 40% of them will fall in the period of time that they're in hospital. That's perhaps not unexpected. These people do have moderately severe physical, emotional, cognitive, perceptual problems. But I still believe that's unacceptably high and that we can do things to minimise falls in hospital. One would think that by the time these patients have been through their rehabilitation and have got to the point of tending to plateau off a little bit and be prepared for going home, that period of transition home would mean we'd have less falls. And even though it looks as though there's less falls here, this is just in the first month. Somewhere between 25 and 30% of these patients who are discharged home after a stroke have a fall in that first month. And again, that's an extremely high rate of falls for a very fragile group who the fall in itself can potentially have some fairly devastating effects. It may not cause injury, but the loss of confidence for someone who's just getting their mobility back can have very profound effects. If we look at over the first year after these people go home, around 75% of them have a fall. So that's 3/4 of them falling at least once and many of them falling multiple times. In the long term, if we look at 5 or 10 years, certainly the rate of falls goes down to 30 to 40%, but I wouldn't argue that anything here has been done to effectively reduce the risk of falls. My sense of what's happening here is that because of all the falls that have happened here, the activity curtailment, the loss of confidence, the less exposure to risk because of these people tend to do less and less over time, is the reason we're seeing less falls, but that's not a good outcome. What we want to see is these people actively engaged after their stroke with their community and having low falls rates. This slide is from some work looking at falls in the 7 months after stroke patients go home from 7 rehabilitation hospitals in Melbourne and Sydney. And again, you can see around about 50% of the patients had a fall in that first month. The black part of the bar shows those who had 1 fall, the shaded part shows those who had multiple falls. So you can see that a large number of these people are falling several times in that first month. Certainly again there's that reduction over subsequent months, but again, is this due to any improvement or is this due to activity curtailment and fear of falling? Even at months 6 and 7, we've still got some people who haven't had a fall up until that time who are having first falls, so that's the black part. And there seems to be a bit of a trend upwards here again. So throughout this period, falls are a major problem for stroke patients. In another one of our studies, just to reinforce this a little bit more, we were looking at an intervention. We recruited stroke patients just before they went home from hospital and said, as soon as you're settled in at home, we'll come in and see you, put in place an intervention program if you're in the intervention arm of our study. On average, it was 2 weeks before patients were happy for us to come in and to get underway. But 28% of them had fallen in that 2-week period. So we can't wait 2 weeks. We've got to get this happening from day one when these patients are going home. I also just want to highlight that it's not just stroke patients. Older people in general do have a peak of falls around the time of discharge and in that first 1 month. An earlier study by Marnie just looked at older people being discharged home. 15% of them fell in that first month and 11% of the falls caused serious injuries, often requiring rehospitalisation. So this is a major critical time, that transition from hospital to home, where falls seem to be quite prevalent. With our stroke patients, what's the cause of that increased risk? Well, clearly the stroke is part of that, but in the rehabilitation process, a very strong focus is on rehabilitating the stroke-related risk factors well. I do believe that there's unrecognised falls risk factors that these patients come into hospital with that haven't been picked up or haven't been dealt with beforehand that they go home with. So they may have vision problems, not have had their vision assessed for the last 3 or 4 years, have polypharmacy, perhaps have a range of other comorbidities that increase their risk of falls that aren't stroke related, that don't really get good management, get good identification and management in the rehab program. So I would argue that we should be doing a risk assessment on these, a falls risk assessment on these patients and putting in place as well as our stroke management interventions to try to minimise and manage any of those pre-existing risk factors. I'd also argue, and we've got a bit of evidence that I'll be touching on around, that patients aren't well prepared for the transition home and they don't realise their high level of risk in that time of transition. So again, this is an area that I think we've got to do better with. Just want to deviate a little bit for stroke and tell you what we know works in falls prevention with stroke. I showed you all the stuff at the start around community dwelling older people. This was an analysis review by Francis Batchelor, who looked at any studies that had stroke survivors of any chronicity, so acute, subacute, very chronic, any setting, so hospital, residential care, community, any sort of intervention, single or multifactorial, so long as they had a falls-related outcome in the study. Only 14 papers were identified, variable quality of those interventions. And if you look at this chart, just to interpret what you see here, each of these lines is a separate randomised trial. If the whiskers on this bar here cross the upright line, it means that there's no significant effect of that intervention. So you can see that virtually all of these studies that did look at trying to reduce falls in stroke patients didn't have an effect on reducing falls. The only one that did was a vitamin D intervention, and that was for a group of patients who were reported as being in a convalescent hospital, which looked as though it was chronic stroke, at least 2 years post-stroke, and a type of residential care, more or less. So if we're thinking about what might work, particularly in that transition home and that first 12 months, this doesn't really help to inform us. So we really have very little research evidence in this space. There was a new Cochrane review published late last year, and this is exercise only, so there's been growth in a few new studies in the exercise area. There was one by Francis Batchelor looking at Melbourne and Adelaide hospitals, using Otago exercise program as a core element and having a risk assessment and a number of interventions put in place. Post-risk assessment didn't have any effect. A study by Kath Dean in Sydney looking at chronic stroke and exercise programs, even though there were some physical benefits of the program, didn't reduce falls. And the third one looked at a chronic stroke sample with a vibration machine, so standing on a machine that gives you a vibration, and there's a bit of work coming out suggesting it might help with some physical outcomes. It's done in combination with some exercise. Again, it didn't have any effect in this population. So even though we've seen some new studies out there, overall still from an exercise point of view and in terms of any of the other interventions, there's no effect on reducing falls. So this is a difficult group, and what seems to work in older people generally doesn't work if we just try to translate it directly. But there is a new study that's about to be published. It's in press at the moment and is available online before publication, that has shown an effective intervention, which is great. My sense is that it's not impossible to achieve reduction in falls in this high-risk group, but we need to do things a bit differently. And this study used Tai Chi. It was a randomised trial. Patients were at least 3 months post-stroke, but on average they were around 3 years post-stroke, so they were getting towards a chronic stage. Average age 70. They had few exclusion criteria, so they were fairly representative of the average older stroke patient out there. And they used a Yang-style Tai Chi. They also had a comparison exercise group of strength and flexibility training, and they had a usual care group. Bearing in mind balance is often impaired in this population, so they did allow participants to use walkers, canes and chairs in terms of steadying, although clearly for a lot of the balance effects of the intervention, those are there just in case they're not being used for hand support. Adherence was quite high, 80% in both of the exercise programs, and the Tai Chi did achieve a 2/3 reduction in falls compared to the other two interventions over that 12-week, 3 times a week Tai Chi program. So that's a very positive outcome, and it does start to show that we can reduce falls in this high-risk group. So I'm going to move on to another somewhat different type of intervention and use that to explore a few issues around adherence. So this is a multifaceted podiatry intervention. It looked at 305 older people, and these people had increased risk of falls and also had what was defined as disabling foot pain. They'd all been seeing podiatrists around problems with their feet. The sample was on average around 75 years of age, 2/3 were women, 1/3 were living alone, 2/3 roughly were taking 4 or more medications, and in terms of falls in the last 12 months, nearly 2/3 of them had fallen. So it's a pretty high risk population in this study. The intervention was looking at feet. Okay, a lot of the exercise that we normally look at in the different studies in falls prevention are whole body balance training and lower limb training. This only looked at feet, looked at flexibility and strength training of the feet. It also provided, so everyone got an exercise program. They also looked to see if patients needed orthoses, and those that did were provided with an orthoses, a set of orthoses, and they also looked at the footwear that the patients had, and if their footwear was poor, they provided them with a $100 voucher plus some advice about what good footwear should be and encourage them to go and purchase some good footwear. The control group just received routine podiatry care. And the study did find a 36% reduction in falls. There was significant improvements in balance, strength and range of movements. So just working around the foot and ankle, that's a very important area from a balance perspective, and there was some very good benefits of the program. So this is the first randomised trial to show the effectiveness of a podiatry-related intervention on falls. I just want to take that study now and move into issues around participation and sustained engagement, because this is a fairly substantial problem. We have a lot of good evidence, and we often recommend things to an older person or an older group of people. How many of them actually take on board, even if they are at high falls risk, how many of them actually take on board and change what they're doing to minimise their risk of falls? So in this successful podiatry intervention, they had those 3 components. The exercise component, 66% of the recommended 3 times a week exercises were completed. So for 1/3 of patients, a reasonably simple, straightforward exercise program wasn't adhered to. If we look at the intervention of the orthoses, 2/3 of the participants needed orthoses and were provided with orthoses. Of those, 55% wore them most of the time by self-report at the end of the intervention. So half of them weren't wearing them. They had problems, they needed orthoses, they were provided with orthoses, they didn't use them. And on the footwear side, 1/4 of the patients had inappropriate footwear that increased their risk of falls, were provided with a $100 voucher and advice, and at follow-up 37% were wearing their new footwear most of the time. So 2/3 were not wearing their new footwear much of the time at all. So we see a moderate problem of adherence, and this is in a study which actually tried fairly hard to minimise some of the barriers, say cost, for example, of the new footwear, provision of the orthoses. They overcame those or contributed to them to a degree and still had quite poor adherence. And if we look at a review of a large number of randomised controlled trials that's been done, they looked at 69 of the studies that were in the 2009 Cochrane review that reported adherence. Even the most simple intervention, popping a pill, so vitamin D and calcium supplementation, 20% of patients who needed this had poor bone strength and so on, and low vitamin D, did not take their vitamin D. And if we look at other interventions, group and walking programs, there's around 70%, home exercise programs around 50% are persisting with these 12 months down the road or at the end of the interventions. So we've got a major problem here of older people, mostly in these studies, people who are at risk, who are not taking on board or persisting with the interventions that we're recommending. And if that's the case, it's little wonder that we're not seeing much change in those falls rates. Now you probably can't read this, but I'll just walk you through a couple of elements of it. It's work that was done by Anne-Marie Hill, looking at older people being discharged from hospital here, and she was asking patients at that time of discharge or just after they went home what type of things they thought were important from a falls prevention point of view. And it was a fairly large sample, 300 over patients, and the things that were most commonly reported, 27% reported behavioural strategies, things like concentrate more, be more careful. 25% reported using a bit more support when mobilising, which is probably not a bad thing, using a walking aid, but it also included using furniture, which is not to be recommended for older people at risk of falls. But these things, that we don't have randomised controlled trial evidence to say that these are effective in reducing falls. While they might sound reasonable approaches, the things we do have evidence for, activity and exercise, 3% of older people who are discharged from hospital thought that was a good thing to be doing from a falls prevention point of view. So if people don't think that it's of much value, it doesn't matter if you recommend it, they're probably not going to do it unless you can make a conscious change in their thinking about the value of this type of intervention. So you've got to do more than just say you need to do an exercise program, you've got to sell the intervention. Similarly with medical type interventions, 4% thought there was something medically that could be done. So these people are not going to go and see the doctor if they have had the odd fall. So adherence is a major problem that I think we've really got to work much harder than we do currently on. The final bit of work that I'll touch on now is around a high-risk group in the community, that is people who receive informal care at home, often very frail, high risk, often with cognitive impairment, and the interaction between the care recipient and the caregiver and falls on that arrangement. This is a very important arrangement because informal caregiving makes up a very large amount of the support that helps to keep frail, at-risk older people living independently at home. If it wasn't for that level of support, many of these people would need to be living in residential care, which is not a good outcome for them, and it's not a good outcome for society in terms of cost. And so this is an important relationship to explore. The carers are often under moderate to high levels of stress and burden, and so little things sometimes can actually cause a major impact on the caring relationship and may be a precipitation of need to go into residential care. And falls is potentially one of those things, falls by the care recipient. The other thing I just want to touch on about carers is that they often do an enormously good job in their caring relationship for the person they're caring for, but they forget about looking after themselves, and that's an important thing that we need to, in our relationships with carers and care recipients, is look at the health and make sure there's time out for health promotion for carers as well, and that way the caring relationship can continue hopefully for a longer period than it would otherwise do. So a group that I was involved in at the National Ageing Research Institute in Melbourne did a study looking at this. We had 96 care recipient dyads. The caregivers were on average 72 years of age, the care recipients 78. 2/3 of the caregivers were female, a third of the care recipients were female. Fairly long periods in the caregiving role, on average about 6 years. Mostly the carers were a spouse, so another older person looking after the frail, high-risk person at home. If we think about the number of health problems, certainly obviously the care recipient would be having a reasonable number. There was on average around 5 health problems for the care recipient, but the caregiver had on average 3 health problems as well, and often things like back pain were reported. So these are issues that could impact upon the caring relationship. Looking at falls risk, we used the FROPCOM assessment tool, and 61% of the care recipients were classified as high risk. They had a lot of risk factors that potentially increased their risk of having falls. So we followed these people up over the next 12 months. We went out to see them shortly after any falls that they had. But just looking at that 12-month period, 198 falls by the 96 participants, by 54 of the 96 participants. So 56% of these people had one or more falls. On average there were 2 falls per person who fell. And there was a high proportion, 2/3 of these people were multiple fallers, so it's a fairly substantial problem in this population. So when we looked at what the scores were like at that initial assessment when we recruited these people into the intervention through to shortly after any falls that had happened, the first fall in particular is what I'm reporting to here, there were 2 things that had changed significantly in that period. The first one was the care recipients' overall function measured by the Bartel index, modified Bartel index. It had deteriorated by about a point. So that doesn't sound like a lot, but in a fairly fragile relationship, that might be enough to tip the scales and mean this person needs either additional care at home or perhaps residential care. The other thing that was significantly different was carer burden. And this, I think, is the most important element of this. And burden went up on average 3 points shortly after a fall occurred. And so this is, again, one of those factors that could tip the caregiving relationship over the edge. So if we can do anything to minimise falls in this in care recipients, we're likely to help to minimise the risk of adding to the carer burden and the need for potential additional care or residential care. We also looked at what services people were receiving at the start of the study and then at the 12-month follow-up. And what you might expect to see if there's been all these falls in that 12-month period is that there might be a bit of an increase in things like physiotherapy, exercise programs and so on, day centres, community rehab and so on. Virtually no change in any of those interventions, and it suggests that the caregivers, the care recipients, and perhaps their GP and other health professionals that they're dealing with are just accepting falls in this population. They're certainly not thinking, what is it that's causing falls? What can we put in place to try and minimise the risk of falls? So again, I think we've got to get in there and try to change that and try to do what we can to minimise the risk of falls in this high-risk population. So that's just a very brief snapshot of a few bits of work that have been going on in recent times that I think have some impact on trying to reduce that lack of change in the rate of falls hospitalisations in Australia. Falls rates are unacceptably high and still are unacceptably high despite that really strong growth in research evidence. And we really need to look at what it is that we can do, take from the research evidence and apply into practice, that hopefully we'll see some of those things being taken on board a bit better than they are now. In particular, we need to think about both research and practice for those high-risk clinical groups, stroke, Parkinson's disease, arthritis, dementia. Think about how do we engage older people in the recommendations that we know are good for them, and also think about the implications around frail older people living at home, particularly those with carers, and trying to help maintain that caring dyad. So I'll finish at that and see if there's any questions.
Anybody got any questions?
Tony?
Yeah, okay. Just on that statement you had about anti-mammary health. I mean, obviously, having worked in the area for a very long time, I think it's interesting that the thing that I always tear my hair out about is decision making and patients' behaviour. And it's really interesting that one of the key things that patients actually said themselves was about
attention please, code blue, ward G62, code blue G62.
How do we change behaviour and related interventions in terms of around that area, and something which obviously is something for the future, but it seems to be consistent with my beliefs and a lot of other clinicians' belief, and obviously what the patients themselves believe.
Yes, it is amazing, and clinicians see it, and the research is showing it that it's very difficult for older people even high-risk older people to actually self-identify with the risk. They often will understand, although not everyone understands that they do have high risk. We did do some work with stroke patients who have high risk at the time of going home. we did a falls risk assessment on them. We talked to them about what do they think about their risk of falling when they go home, and they didn't think it was a major problem. And that we talked to them about what they could perhaps do, and it was very similar to Anne-Marie's results. So, you know, people who do have high risk don't necessarily personalise, and that's something we have to work with them and try to get that buy-in, because if we can't change that, we're wasting our time.
Any other questions? Thank you very much, Professor Hill, for a really informative talk.